It's an honor to present our first presenter, our keynote speaker, Tommaso Barba. I explained to him what Barba means in Croatian last night, so he learned a bit of his culture, our culture, but you know, he's Italian, so it's neighborly. Tommaso, please join the stage. So, yeah. Tommaso is coming from Imperial College London, and he's gonna give a talk about the difference between antidepressants and psilocybin in treatment of depression. So, Tommaso.
Thank you so much.
Yeah, is it on?
Nope.
No?
No? Yes.
Yeah, all right. Great.
Do I have a... Okay. So, hi everyone, I'm Tommaso. I'm a PhD candidate at the Center of Psychedelic Research at Imperial College London. My research broadly spans psychedelic neuroscience, and in the previous years I've done a lot of work in trying to understand how psilocybin, which is the active ingredient of magic mushrooms, compares to classic antidepressants to treat major depressive disorder. And the presentation will briefly introduce the topic of psychedelics overall for people that might be less familiar with the classes of these compounds, and then how they work and how they compare to existing treatments. And yeah, I'll just wait a second. Okay. So, first of all, what are psychedelic substances and how do they work? The term psychedelic encompasses quite a broad class of compounds. First of all, we have classic psychedelics, which are known for affecting all in a similar way the serotonin 2A receptors in the brain. And we have psilocybin, that is the active ingredient of magic mushrooms. We have DMT, which is the compound contained in the shamanic brew ayahuasca. We have LSD, that is semi-synthetic, and it also derived from fungus and was synthesized by the Swiss chemist Albert Hofmann. And then we have mescaline, that is contained in some cactus like peyote. Then we have other drugs that are more called like atypical psychedelics, and with them we have MDMA, that is more of an empathogen because it doesn't induce the same effects that classic psychedelics, but at the same time can induce the strong feeling of empathy and openness and reducing of the fear response that can be applied really well with therapy. And then we have ketamine that at some doses can also have psychedelic effects, and given its legality is the one that is now most used in clinics to treat depression. I think it should work now. Okay. Maybe next slide. Okay. So, first of all, are psychedelics actually dangerous? If you're here, you probably think they might not be as dangerous, but I will just give a brief overview. Like what the research has shown until now is that classic psychedelics are actually not addictive. Indeed, they are not affecting circuits in the brain that are involved in reward processing, like other drugs of abuse, like cocaine and heroin and alcohol and so on. They also have a very low brain toxicity, and the level of psilocybin or LSD that someone needs to take in order to be toxic on the brain, it's so high that probably no one has ever taken it. And as you can see from this graph, which was published like around 15 years ago in the prestigious medical journal Lancet Psychiatry, which included different type of drugs for their effects on their harm that they give to people and the harm that they give to people assuming them, you can see that the first drug for danger was actually classified as alcohol, which is especially harmful to others, but is also particularly harmful to individuals consuming it. And then when we go down, we have other drugs like heroin, which is more bad for users, assuming them, that for others around them. Then we have cocaine, crack cocaine, and so on. And at the end of it, you can see that there are classic psychedelics like psychedelic mushrooms and LSD. And this was a paper that caused a lot of controversy. It actually caused my boss to be sacked by the English government because they really didn't like that people should not drink, while it would be safer if they would assume other type of drugs. But it still stayed in the medical field, and actually later on more and more research came out that actually confirmed the results that were found in this paper. And in terms of subjective effects, how are psychedelics when people are assuming them? And what you can see from this graph is that they cause quite a complex and peculiar state of mind that is normally characterized by increased imagery, so that people normally report visions while they are under the influence of psychedelics, which can be either more, I would say, simple in nature, like geometry and so on, but they also can become quite autobiographical visions, where people normally report seeing memories from their past, or abstract symbolic visions and so on. Then also people feel normally disembodied. They can have blissful feelings, some feelings of ego dissolution, especially at high doses, that indicate this state in which people normally feel disconnected by the normal sense of self, and they can feel connected with everything that is around them. Then sometimes people also have synesthesias, that are this phenomenon in which persons maybe coming from the auditory system and the visual system are mixing, so that people sometimes can hear the sound of colors or so on, or maybe they can see the color of sounds, which is also quite common as an experience. Okay. Maybe push it. Yes. Okay, so in terms of basic pharmacology and how this drug works, they normally act specifically on this particular serotonin receptor that is called serotonin 2A receptor. And this receptor is particularly present in higher brain areas like the prefrontal cortex. So basically these drugs act on the parts of the brain that make us more fundamentally human, if we can call it in this manner, as well as in the visual cortex, and that's the reason why they normally create this increased visual activity. And what they do in this, by acting in this receptors, is that they dysregulate the cortical brain activity in this brain area, so that it become more entropic and less constrained by the usual constraint that gives rise to the type of consciousness that that we normally inhabit. And there is some good research that shows that the more you occupy these receptors with agonists, the more intense the psychedelic trip is, as you can see from this graph. And the more you occupy it, the more subjective effects people feel. And if you block these receptors and you give psychedelics to people, they don't feel basically any subjective effects at all. So even if the pharmacology of these drugs is complex, it still seems that it is heavily reliant on these specific receptors. Next one. And here a bit of a stronger deep down into the neuroscience. As you can see from the first graph, which is very famous, and you probably have seen it around on social media somewhere, it shows like the connectivity between different brain areas under placebo and under psychedelics. And as you can see from the first graph, normally when we are in normal waking states, our brain works in more predictable manners. So more similar networks, they communicate with more similar networks and so on. While under psychedelics, everything become more entropic and disorganized. So different brain areas that they normally don't communicate, they start to communicate together, and this creates a state that is less predictable. It's like if there is someone that is normally directing an orchestra of different people singing, it is as if the person at the center will stop working and everyone will become free and able to do what they want, creating this brain state that is particularly peculiar for that manner. And then we also know that psychedelics increase what we call neuroplasticity, and this has been found in animals specifically due to the complexity of studying neuronal cells in humans. But basically neuroplasticity is defined broadly as the capacity of the brain to be shaped and molded by the environment, and its capacity to change after the presentation of new stimuli. And even if neuroplasticity sounds good as a term, it's not good per se. Indeed, other drugs like cocaine also induce neuroplasticity, but in the wrong brain areas, like in the reward centers of the brain, so make people more likely to consume the drug again. But given the effects of psychedelics in the higher brain areas of the cortex, if combined with supportive therapy that helps people entering in a certain brain state and having a new view of the world, might actually make psychotherapists more flexible and easier to perform on patients that normally might be quite resistant to the input of the therapist. So, as in trying to use a metaphor, similarly to clay, psychedelics administered in the right condition might actually reshape how someone sees the world and the people around them and also themselves. And I think here lays the key therapeutic effect of these drugs, because they make this brain state more molded and more capable of external and internal input, so that people can more easily change bad dynamics in their life that maybe they've been carrying on for a very long time. And this is a snippet from a documentary that we made a few years ago in a trial of psilocybin for depression. So just to give you a glimpse on how a psychedelic experience feels like. Okay, getting into depression briefly. What major depression is? Major depression is a disorder that is characterized by persistent low mood, fatigue, lack of appetite, and the similar symptoms that last for more of 2 weeks in duration. It is intense enough to impair the normal functioning of someone affected from it. And the major depressive disorder is probably the most common psychiatric disorder, together with anxiety disorders, to the point that almost a third of the global population will have at least one major depressive episode in their lifetime. And it's a disorder that is rapidly rising in its prevalence in our society for reasons that are still yet unknown, but it's quite fascinating on how it's skyrocketing in our normal culture, despite us probably like living in conditions that at a superficial eye might be more comfortable than the one we ever lived before, but yet there might be something off in how we are approaching the world these days. And the recovery from major depression is not that simple. Indeed, around just 1 on 8 people that recovers from a major depressive episodes normally stays depression-free, and it tends to come back in cycle at different time points in the life of people. And we run 2 different psilocybin-assisted therapy trials at Imperial for treating major depression. The first one that was published in 2016, it was the first pilot in which we treated people affected by major depressive disorder with treatment resistance. That is, that these people normally were resistant to at least 2 different courses of antidepressants. We found that 2 doses of psilocybin combined with therapeutic support catalyzed significant reductions in depression that lasted up to 6 months in this trial population. This was quite remarkable. Indeed, there was no other study before in which a psychiatric drug that was administered twice was capable of having effects that were expanding for several months after the effects of these drugs were vanished. And as you can see here, it's not a magic bullet, like it didn't work in the same way for everyone. And in most of these patients, depression came back at some point in their life. And this is another interesting point, because it kind of shows that psychedelic therapy might be something that is administered in different cycles and is just not given once and then people are depression free, as a lot of popular media have depicted it. But it works, and it works for several months after the effects of these drugs have been cleared from the system. And the next one was a follow-up study in which we compared psilocybin assisted therapy with classic antidepressants treatment in order to see how these drugs would work differently in treating this disorder. And as you can see here, it's just not a drug that is administered. It's an experiential treatment, a sort of what I like to call a surgical treatment in the psyche of these patients. Indeed, they come in and they first are prepared by psychotherapists with a few sessions of psychological support in which they are familiarized with what can happen and they talk about their life. And then in the day of the treatment, they come into the room that is something looking like this, as it's very important for us to create a space in which patients can have a beautiful experience. They are accompanied by music, a playlist that is specifically designed in order to mimic the different phases of the psychedelic effects. And then there are two supportive therapists in this room that are guiding people through these experiences. And then later on, they have some follow-up visits in what we call integration, in which patients are talking about these experiences and what they lived in order to integrate it in their everyday life and make active changes in order to maintain what they experienced during these sessions. And going back into classic antidepressants, how are psychedelic treatments different from classic antidepressants? Well, classic antidepressants, especially SSRIs, which are the most commonly prescribed, they fundamentally work by reducing the intensity of negative emotions so that people are more able to cope with stress and with environmental triggers that they have around, because their emotional activity is reduced. So something that maybe before was overwhelming, it becomes more tolerable. But the problem with this approach is that in a lot of times are not only negative emotions that are effective, but also the positive ones. And something happens to people that is clinically called emotional blunting, in which they become less sensitive to the negative emotions, but also to the positive emotions, so that life becomes more tolerable, but not necessarily better. And in a lot of cases, these drugs are prescribed without any form of therapy, and people are not actively changed. They don't make the differences in their life that will allow them to have more positive lives. They're just numbed in a lot of cases. And I think this is a problem in general, how these drugs are prescribed. And we can see it also from research, because if you combine antidepressants with psychological therapy, the effects are stronger and more long-lasting than when people are just prescribed these drugs and told to just continue with their everyday life. But of course, this is easy, because people don't want to change. They don't want to face their demons, they don't want to face their fears, and this is what happens in psychedelic therapy. And I think it's either it's blessed and it's cursed, because I'm not sure in the future how many people will then actually be open to try something that will force them to confront what they've been running away from maybe their whole life. And it's this different type of approach in which you confront instead of suppressing and running away from it. And maybe from the confrontation is where the active growth can come. And regarding the pharmacological effects, and I will try to speed up a bit on this, but classic antidepressants, they seem to activate due to downstream effects in the serotonergic system, another type of serotonin receptor that is called the serotonin 1A receptor, which is more located in limbic areas of the brain that are controlling emotions, and it regulates anxiety and stress tolerance. And basically what it does by being activated, as I briefly mentioned before, is that it stimulates coping in patients. And if you take out this receptor in animals, you can see that these animals shows higher anxiety and depressive symptoms, and this underscores its role in mood regulation. And by elevating serotonin through classic antidepressants, it seems that these receptors gets more activated, and that it's how people become more resilient to negative emotions in this passive manner that I briefly outlined before. While the other receptor, that is the serotonin 2A receptor, it facilitates brain plasticity so that it makes the brain more flexible and open to change, particularly during challenging conditions. And as I said, it's more expressed in the prefrontal cortex. And the interesting thing is that how the serotonin system seems to work is that when your brain produces serotonin to tolerate stress, at an initial level, your brain is just primed to cope passively, to resist more. And you increase serotonin, and your brain is like, okay, I will produce some serotonin, and then it will activate the serotonin 1A receptor so that you will be more capable of coping with these emotions. But then, if the stress continues, if you increase the serotonin levels, at some point there might be a switch in which the serotonin 2A receptor pass from a normal, more dormant state of low affinity to a state of high affinity, and it's kind of like your brain gets this implicit message that if you don't change, you perish. And it seems that the same mechanism is activated through other modalities that are related to extreme stress. Sometimes you see people radically changing after a particularly complex period of their life, and it seems that the serotonin 2A receptor is in action, and it's the same for like other spiritual practices like fasting and isolation and so on. They're all activities that it seems they activate a similar mechanism of active coping. And in our trial at Imperial, in which we compared psilocybin versus classic antidepressants, we gave at the two different groups either 2 doses of psilocybin that are high, around 25 milligrams, that are equivalent for around like 3 grams of magic mushrooms, more or less. And on the other group, we treated patients with 6 weeks of an antidepressant course with Lexapro or escitalopram, that is one of the most used SSRIs on the market. And both groups received the same amount of psychological support. So it was either antidepressant and therapy or psilocybin and therapy. And the interesting thing that we found is that, of course, we hoped to see people getting better in the psilocybin group in the depressive symptoms, but they did not. And when we looked at the negative symptoms of depression, so like sadness and similar negative symptoms, the 2 treatment performed more or less in a similar manner. Psilocybin seems to have maybe a slightly adjunctive positive effect, but in terms of negative symptoms, the 2 treatment were comparable. But then, when we looked at how people were feeling well, so in their well-being, psilocybin really outperformed classic antidepressant, and similarly was for other scales measuring meaning in life, how connected they were with people around them, how they were able to psychologically flourish after this experience, their sexual functioning, their capacity to feel emotions, and so on. So it seems that the advantage of psilocybin is not really in making people feel less sad, but in making people feel better. And you can see here a bunch of measures in which the only one that did not outperform was actually the depression one, while all the other ones, basically, psilocybin outperformed classic antidepressants. And you will ask why these dimensions are important. Well, because patients really care about them, even if psychiatrists sometimes tend not to. Indeed, there is this interesting study in which it was asked to either physicians and patients what they thought was meaningful to be recovered from depression. And as you can see from the first graph, doctors, they prioritize negative feelings like blue mood, despair, feeling down, feeling depressed, little interest or pleasure in doing things, while when it was asked to patients, the most important point that they care about was how meaningful was their life, how much they enjoyed it, how satisfied they were with themselves, how capable they were to connect with significant others. And so it kind of shows a mismatch, that maybe we are treating depression in the wrong way, that we are really caring about not making people feel less sad, but people want to feel good. Okay. And briefly focusing on the sexual functioning aspect of these drugs and how they impact differently, because I specifically focus in this area of research for a while. Sexual dysfunction is particularly important in depression treatment because, first of all, people with depression, they already struggle to have a satisfying sexual life, which I think it's a very important aspect of well-being. Indeed, is one of the fundamental human driving forces, and it's really important when someone feels well. They normally want to connect with the people that they love, and depression already impairs this. But on top of this, sexual dysfunction is one of the most common side effects of classic antidepressants, where normally libido is reduced, but also people are not capable of having orgasms anymore, of having like any sort of sexual activity anymore in a lot of cases, and this happens due to downstream effects on the serotoninergic system. And it's a very strong risk factor for people stopping antidepressants. Indeed, in a lot of cases, they start taking these drugs and then they feel that they're getting these side effects, and then they stop taking them, and then maybe they jump into depression another time. So in order to try to understand how these two treatments were impacting differently these aspects of well-being, we asked people different questions related to their sexual life, how much pleasure they were capable of getting from sex, how much they were able to communicate with their partner, how satisfied they were with their partners, their bodies, and similar questions. And what we found was that people treated with psilocybin, but not with escitalopram, they reported increases in their capacity to feel pleasure in their sexual life. They also had significant improvements in their capacity to communicate with their partners, with satisfaction with their partners, while the importance of sex in their everyday life, it did not change in any of the groups, showing that it's not that psilocybin makes people hypersexual, it just changes the way in which they approach to their sexual life, potentially. Appearance satisfaction improved in both groups, showing that it might be that people felt less sad and then they were more satisfied with their body. And when then we asked another similar question to people, that was how much their sex life was impacted by the start of the treatment, this is when the results got really interesting. Indeed, you can see from the top graph that people treated with psilocybin, almost half of the sample reported improvements in sexual arousal and sexual interest, while half of the sample of the people treated with antidepressants, they reported decreases from the start of the treatment in these similar dimensions, kind of showing how these drugs, even if they might affect similarly something like negative symptoms in depression, they still have a very different impacts in other aspects of people's life. So, trying to recap what I did until now, it might be that we will have two different ways to treat depression in the future. One is by acting on the more passive coping system of treating depression, that is by increasing the activity of serotonin 1A receptors through classic SSRIs, which stimulates a form of more passive coping and resilience that in some cases might be very useful. And on the other side, we have the treatment with psychedelics that activate the serotonin 2A receptors and activates this more active changing path of depression, which is the one that I briefly outlined below. And an interesting thing is that we found through subsequent research that you can actually combine these two treatments, and it seems to work relatively well. So it's still safe to give psilocybin to people already treated with antidepressants, and the research is still in its infancy, but it seems that it works, and it might even reduce the challenging aspect of the experience. So it's promising, which for the medical field is very important, because you normally don't want to take people out of these drugs if they already started a curse for quite a very long time, because it can destabilize them. And we actually found it that if people are taking off SSRIs, then sometimes they might come destabilized into psychedelic sessions. It's still not clear for what's going to happen in big numbers. We have reports from retreat centers around the world where psychedelics are given, for example, in the Netherlands and so on, that they're saying that there are some extra difficulties in giving psychedelics to these patients, but it seems that overall it's a safe choice. This is a quote that comes from one of our participants that actually described this interesting difference between these treatments, in which it said that while the treatment with escitalopram that she had previously in her depression treatment nulled her to be less scared, psilocybin had made her realize that fear is actually not something that should be scared of. So, looking at the long-term changes at the follow-up of that study, we looked what patients did in their 6 months after the treatment in our study. And at the 6 months endpoint, we found pretty similar results, so that people treated with antidepressants and psilocybin had similar improvements in depressive symptoms, and the sustained improvements happen in both groups. Also likely due to the high-intensive form of therapy that they got in this trial that allowed them to stay to keep these effects in a longer manner. But then when we looked at other measures, like for example how capable were people to work in their social and to function in their social and their work life, psilocybin outperformed classic antidepressants. And similarly was for feelings of meaning in life, and also for how connected people felt with themselves, with significant others, and so on. And an interesting caveat of this study is that most patients started another form of treatment, or they took psychedelics again, or they went into therapy, so they did not stop their journey after they finished the study, but a high proportion of them started either antidepressants, went into psychedelics, or had another form of therapy. The use of the treatment was not different between the two groups, which kind of speaks to the point that they might compensate each other, but it's still something important to mention when presenting these results. How much time do I still have? Am I? Okay, nice. So, now looking at the brain, and I try to make this simple way I can, but what happened in these two different treatments when we looked at the neuroimaging aspect of it? We looked at an index that we called modularity, that is basically how modular and segregated your brain is, so that it refers to this organization into different networks of regions that maintain specific tasks while being independent to each other, which is something that it can be called also rigidity, maybe, in more colloquial terms. And we looked at the before and after changes in this modularity index, and the interesting thing is that higher modularity in your brain is associated with depression too. So if your brain is more rigid, it might be more prone to depression. But interesting enough, modularity is also associated with sharp cognition in some tests. So it kind of shows that it's not just a bad index. And sometimes if you have a brain that is rigid, it might be very computationally efficient. Like you get a question, you get an answer immediately, but the answer might not be something that you haven't thought about before. And in some cases, different problems have the need of different answers. And as you might guess, we found that the level of modularity were decreased in patients treated with psilocybin 6 weeks after the use of the drug, while in the escitalopram group, the level of modularity remained the same. And the interesting thing is that this decrease in modularity was associated with improvement in depressive symptoms after the study. So a more flexible, less rigid brain might be more happy, and it might be that the secret of happiness is indeed freedom, as the Greek philosophers used to say. And so, from a neuroscientific perspective, how does psychedelic therapy work? So, you can imagine your brain as this sort of valley in which there are different points and loops in which sometimes there's a valley, sometimes there's a mountain. And what happens in depression is that given to this rigidity of the brain, you might have these valleys in the brain that become particularly steep, in which people get blocked on. So you might be stuck in this version of yourself that is like, I'm unlovable, people don't like me, the world is a scary place. And this becomes very insensitive to external information. Like, for example, people with depression, they are more likely to see themselves in a negative futures. They are less likely to interpret positive comments from others as related to their character, and might just be on the situation. But then the negative ones become very related to their character. So they develop develop these biases in which they see the world not as it is, but as they are. And it's a quite fascinating mechanisms. But the point is that they get stuck in these loops, and it's really difficult to take them out. And the psychotherapy normally can do that in a very long amount of time. But what happens with psychedelics is that they flatten this landscape in which the mountains become less steep and the valleys become more profound. And this is shown in the psychedelic experience, in which people, when they are under the influence of psilocybin, they can go through a wide range of emotions during these experiences. So it's not that it makes them less sad immediately or happier. Like, I've seen psychedelic sessions, they were characterized by an extreme amount of negative emotions, people crying like babies, like feeling that they were dying. So it's like it's a complicated process that sometimes like reminds of what we call the hero journey. That is this ancient myth or archetype in which it's represented in a lot of different fairy tales or stories from the past, in which there is this journey that people have to confront in order to develop themselves into a better person, normally through a lot of challenges, and then later on through a resolution of these challenges in order to become this new version of themselves. And it seems what happens in the psychedelic sessions too, and especially the initial parts are characterized by fear, anxiety, and relieving of negative memories and so on. And then if people are able to confront them, to go through them instead of running away from them, it seems that they are then capable of overcoming them. And it seems in our depiction of this, that is due to this reduced landscape in the brain dynamics, in which people are just more flexible and they can move through these different emotional states freer later during the experience. But the interesting thing is that this energy landscape of the brain, it becomes reduced after the experience, and this is shown by the reduced modularity, so that people are then more capable of moving through these different emotional states better after the experience, and especially when it's combined with a form of supportive therapy that allows them to pursue active positive change in their life. It seems that it can be particularly meaningful in order to move them away from these negative attractors. And looking at SSRIs, when we looked at what happened in the brain of people treated with these medications, and this is something that is confirmed by a lot of previous research, given that these drugs have been there for a very long time. It's been found that these compounds, they reduce the intensity of negative emotions by reducing the activity in the amygdala, so that people, when they see an emotional phase, they have less strong reaction. And the interesting thing is that this has been found to happen both for negative phases, but also for positive ones, kind of reflecting what I told you before about this reduced emotional sensitivity. And we found a very similar effect in our study, in which escitalopram blunted the emotional reactions to all the phases, either with positive emotionality or negative emotionality, while psilocybin did not seem to have such an effect. So it did not affect the expression of emotions in the brains of people. So, how does it feel like? In case the video won't work, I have here some quotes from our patients that are depicting a bit how the psychedelic therapy felt like for them. And I just leave them here for a second so that you can read through it. But general themes are these themes of increased connection with themselves, with the world around them, this capacity of escaping from the prison of their mind. Sometimes these encounters with entities and images that were coming either from their unconscious or really not sure what, because there's something in psychedelic therapy that at particularly high level can enter in something that we can call like a sort of spiritual realm, in which people are depicting images and experiences that are somehow connected with with several spiritual traditions. And it might be that there is the state of the brain that is less constrained by our ego, that is more capable of having these experiences. And I'm ending here. This is all our group that I want to thank. I did not personally conduct most of the research that I presented here. It's been done by this amazing group of people in quite a collaborative manner. And this is the end of it. Leave you here with a quote. I do a lot of science communication around psychedelics and on LinkedIn, so feel free to read it. And yeah, I'm ending here. I don't know if the video is, otherwise we just skip it. Well, no. Thank you so much. Thank you.
Thank you, Tommaso, for amazing talk. I'm just gonna join you stage. We have I don't want to test the lords of technology because they failed me twice already. This was fourth pointer that we tried. So it's not 4 times the charm. So I think we have a time for a few questions. Amazing. If you're up for it.
Yeah, absolutely.
Yeah, all right. So any questions? Yeah, all right. So we already have one.
Yeah, very decisive. I like it.
My question is there some research that you do on microdosing? We see like only macrodosing.
Yeah.
Does microdose have effects on depression?
So the microdosing question is very tricky because we have been trying to study it in a lot of different ways, and what the most recent research tells us is that there is a huge component of placebo expectancies that plays into the effects of this low dose approach. But the study that we conducted was mainly on people like using it for well-being purposes, and what we found as this main finding was that people improved in a very similar manner as soon as they thought of taking a microdose. So either if they were on placebo or they were on a microdose, if they thought they were on a microdose, they improved really well. If they did not think they were, they did not improve. And similarly was for the ones in the placebo group. And recently there's another study that was published, I think like a couple of weeks ago, in the use of microdosing for treating ADHD. And even there, like as soon as people saw they were on a microdose, they improved in a similar manner. And actually the placebo group in that study improved more than the people that were actually on microdosing on ADHD symptoms. The question still stays open for depression, and I think there might be a role in either depression or anxiety, and we are now conducting a follow-up study in people with mood disorders, and there are other groups around the world that are specifically focused on this, and I'm like personally relatively positive that there might be something there, because like if you give SSRIs to people that are not depressed, they won't improve any further. They might just get worse. It might be similar to microdose, which is different to the macrodose approach, because in that one, for example, we also found, and I didn't present it here, but if you give psychedelic assisted therapy with people that are healthy and they don't have any depression or anxiety diagnosis, but they never tried psychedelics before, their well-being improves for months after the use of this experience. And this is another finding that I think is a bit the elephant in the room of this all research, because it's just kind of like say, okay, like it's just for people that are very sick, and I don't think that is. But before arriving to that point, I think we are unfortunately very far from for the medical system, especially.
Thank you. All right. So, who was first? 1, 2. All right.
Okay, I just read few studies about this microdosing, and what I found interesting, and this is actually environmental, scientific, ethical constraints from the research institutions. Because some, let's say, schools or paradigm force the longer take, and because of this high-risk ethical bullshit proposed by alcoholic deans, they could make the longer studies. So could you please comment on these scientific methods in terms of microdosing? Because what I saw in the literature, there is no proper microdosing which goes through the longer period, but 2 day off, 2 day on, like the petrol in the 70s.
Yeah, and I would say overall it's a problem because it's been for us way more complicated to do studies on microdosing than to use the high dose approach. And the reason for this is that because they're still illegal drugs and it's been impossible ethically to allow people to take them at home. And the problem of this is that then people need to come 3-4 times, maybe a week at the hospital, and they live far, and then this that doesn't work. And we were capable of conducting studies on people that already had their own microdoses, and they were already planning to take them, and that's the best approach that we ended up using. And in other groups that they used the more controlled approach, they gave it twice a week in order to make this happen. But the problem is that is only just for a few weeks. And I agree with you that there are not longer studies, and there might be in the future, there might be not, but it's definitely a problem of the paradigm in which it's done. And there is not an easy solution about it, because until they are classified as very legal, it's very difficult to conduct research.
Okay, well, we can move on. Yeah, we have another question here.
Okay, so first of all, the presentation was great, lots of useful information. But my question is, how does the therapy work precisely? Is it given on a weekly basis, or every month, or every few days?
And good question, and I would say we don't know yet. What we do is normally having this 2 preparation session that lasts normally an hour or 2, and then the therapeutic supervision, and then again 2-3 integration sessions, some of them in person, some of them online. And the therapeutic approach mixes elements of psychoanalysis, acceptance and commitment therapy, and depth psychology, and so on. But other studies around the world, for example, for smoking cessations, they use cognitive behavioral therapy, and that also worked well. So it's there's no clear definition in which type of therapy needs to be used. And the other big problem about this is that in trying to get psychedelics through the medical model, combining them with therapy has been a shit show, just said in very crude terms, because the American FDA, they don't like the idea that you need to give therapy in combination with a drug. And so all the companies that are trying to produce this molecule, even if they think the therapy is useful, they are really trying to cut down the therapeutic support to maybe having a nurse or something like this, because otherwise it won't get approved. And the idea is that you can insert therapy back later on, which it's the best case scenario. The fear of this approach is that even if it passes, it might pass and that's going to be good, but then it might not, because then the effects might not be as good as the one combined with therapy. And then it might be that then gives rise, especially to some country like America, to a bit Wild West situation, like with ketamine, in which people just want to make money out of it, and then it's the side effects might rocket up. But at the same time, on the other side, you don't want to give a super expensive package of therapy to people that might not need it. And people in this room, they might also know that they might have very positive effects from just taking psychedelics in a controlled setting, maybe with their friends, with not a lot of therapeutic support, and then yet you achieved really beautiful insights about yourself. So that's also a possibility, and the problem is that we don't know yet, and until we try to move forward, we won't probably know.
Thank you, Tommaso.
Thank you.
So we have a question maybe for one more, but we also have a question from online participant.
Okay.
I think that it was answered in your talk, but you just, short answer. So the question is about severity of depression. Was it just severe depression, or was it different levels of severity included in your study? And did you like made the differences between different types of severity of depression?
Yeah, so it was from moderate to severe depression, and as far as I'm aware, we did not make sub-analysis to see the different effects on these groups.
Great. Martina? Yeah.
So it's connected maybe to this one. Okay. So when you said that sometimes we have cycles with depression, so do you have information about the variables? So what are differences between people who had these cycles or those who recovered very well from the first therapy process?
So not in our studies specifically. What we know from like existing research is that like sometimes there are predictors like that are either environmental and psychological, like because depression is just, it's not a disease of the individual itself, and if you have either like also very positive psychedelic session and then you go back to an environment that will more likely make you depressed, it's way more likely that you will relapse in depression. And that's again another big elephant in the room of this old psychiatric research, that if you live in a condition in which you don't have money to get to the end of the month, like you have kids you struggle to take care for, you live in an abusive environment, like maybe you should be depressed in that way. Like maybe like there's something that your brain is telling you that this is not the right way of living. If you live like in this hyper-urban environments in which like you have no connection to nature, no connection to like significant others around you, like you can take all the psychedelics in the world and then you might still feel depressed because there's something existential about it. And I think this is another thing that is not really taken care of. And again, most of our studies are conducted in people that are white and coming from relatively wealthy or middle-class backgrounds, and it's normally when it works better because they have an environment that it will be more likely to be helpful for them. And you see it also like in social studies in which rates of antidepressants prescriptions are 3-4 times higher in areas of low socioeconomic status, and despite this they seem to work way less well in this in these areas. And again, because then you just number people that are living in bad conditions.
Great answer.
Thank you.
Yeah, I think that's it for the questions because we are running low on time and we want to keep, schedule tight. So one big applause for our Tommaso.
Thank you so much. Thank you. Thank you. Thank you. Thank you.